Good evening, everyone. This is Ron from HKL Oncology. Very proud that we will be kicking off with our HKL Radiotherapy Series 2026 with none other than Skin Malignancies. So, grab a coffee, relax, pay attention. Hopefully, we all will learn something out of this. Moving on. So, what can you or anyone tell me about these two distinguished gentlemen? What do they have in common? Well, it's quite simple actually. Uh, they all have some kind of skin malignancy, with Hugh Jackman having been diagnosed with BCC of the nasal ala before, and Bob Marley succumbing to acrolentigenous melanoma. Moving on, this is actually the organ of interest for today, the skin, which is typically split into three separate layers: the epidermis, dermis, and also the hypodermis, with the epidermis being something along the lines of about 0.03 millimeters to 1.5 millimeters, the dermis from 0.5 millimeters to about 5 mm, and the hypodermis ranging anything between 1 to 30 millimeters. For those that know me, my hypodermis is probably around 60 to 70 millimeters. For today, our focus is mainly at this layer. So skin cancers can largely be classified into two separate categories. They can be melanomas and everything else. And within the melanoma group, you have the superficial spreading, you have the nodular type, the lentigo malignas, and also the acrolentigenous. For the non-melanomas, we have basal cell carcinoma, BCC, squamous cell carcinoma, SCC, Merkel cell carcinoma, MCC, Kaposi sarcoma, angiosarcomas of the scalp, and also cutaneous T cell or B cell lymphomas. Melanomas in general arises from melanocytes. They are thought to be less common, however, they are believed to be much more aggressive than other kind of skin cancers. They also denote a more systemic natural history of the disease. Though with that said, the management is still with definitive resection. Unless, of course, we are talking about a large lentigo maligna, or if there is any kind of inoperabilities due to clinical comorbids, then in those kind of scenarios, we can consider some kind of definitive radiotherapy, but for all other kind of melanomas, it is still resection. The role of adjuvant radiotherapies is still quite debatable, as there is evidence which shows that there is improved local control, but there is no data to support any kind of overall survival benefit. AJCC has also moved on to come up with the 8th edition staging for melanoma, and if you can see, the primary tumors are defined in terms of its thickness as well as the ulceration, which denotes a A or B suffix, nodal involvements, which also include MSIs, which is not microsatellite instability, but instead microscopic satellite lesions, and also nodal involvements. And the M would also be separated to involvements of skin, subcutaneous regions, lymph nodes, to lung for 1B, and also other visceral sites for 1C, and brain to 1D. And of course, the LDH here would then give us a 0 or 1 suffix. So on examinations, most of the time we would say that there is this ABCDE rule, where there is asymmetry of the skin lesions together with irregularities of the border, and also variegations in the color, and a diameter of more than 6 millimeters with evolution along with time. So like what we mentioned, management is of course through excision, and we would want there to be a very good excision margin with all kinds of oncological surgeries. So for a melanoma that is in situ, we want a margin of at least 0.5 cm. Anything less than 2 millimeters in thickness is 1 centimeter margin, and anything more than 2 millimeters in thickness, we want at least 2 centimeters of margin. Adjuvant radiotherapy, like what we mentioned, was debatable. However, we should consider, especially if the HPE returns with deep desmoplastic melanomas with narrow margins, extensive neurotropisms, or even locally recurrent diseases. Any kinds of stage 3 disease with clinically appreciable lymph nodes or ECEs, especially if there's more than one node in the parotids, 2 or more nodes in the neck, or 2 or more nodes in the axilla, or 3 or more nodes in inguinal regions. So typical prescriptions for melanomas in the adjuvant setting would come along the lines of 50 grays in 25 fractions, 60 grays in 30 fractions, or 66 grays in 33 fractions. However, like what we have mentioned, the mainstay of treatment here is still with adjuvant systemic therapies for patients that are stage 2 and above. And these can be immunotherapies with nivolumab, ipilimumab, pembrolizumab, or even targeted therapies, especially if there is BRAF mutations. Non-melanomas, these are quite rampant. In the US, they've actually recorded more than 2 million cases per year, with BCCs more predominant than SCCs, and with males being more commonly affected than females at a ratio of 4 to 1. In Malaysia, according to the 2012 to 2016 Malaysian National Cancer Registry report, non-melanoma skin cancers actually ranked number 10 among all of the cancers that Malaysians are facing. So, looking at the same Malaysian National Cancer Registry report, but instead for 2017 to 2021, we can see that for males, the incidence has actually increased from 3.1 for 2012 to 2016 up to 3.5 in 2017 to 2021. For females, however, got good news. From 2.3, it actually went down and has been removed from the top 10 list of malignancies. Non-melanomas, they have a preponderance towards anatomical skin areas, of which the high-risk areas would be the mask areas, which corresponds to our mid-face, the central area where eyelids, eyebrows, periorbital nose, lips, chin, mandible, preauricular, postauricular, the temples and the ears, the genitalia, hands, as well as feet. Moderate risk being the cheek, the forehead, the scalp, the neck, the pretibial region, and low risk being trunks and extremities. The mask areas also sort of corresponds to our embryological fusion lines, which will represent some form of higher risk for deep invasions as well as increased risk for local recurrence, because after all, any kind of fusion lines would denote itself as a anatomical fault line. So what does this mask area look like? It's something like this. So a non-melanoma, which is BCC, actually arises from basal cells in the epidermal layer, and these can be further separated into 4 common groups. It can be of the nodular type, which is the most common variant for BCCs, and usually it starts off as a papule with central umbilications, which will later on ulcerate, which is what we call a rodent ulcer. These can also sometimes be pigmented, sometimes blue, sometimes brown, sometimes black. Superficial BCCs, which are red and scaly macules with very vague margins, and these typically happen over on the trunk. Morphoid ones, which are single, flat, indurated, and very, very ill-defined. And usually for the morphoid type, there is also a lot of perineural invasion. Infiltrative BCCs are instead opaque, yellowish, and it sort of blends in with your surrounding skin. Histologically though, these infiltrative types have a bulk consisting of neoplastic infiltrating reticular dermis and also subcutaneous tissues. So looking at these pictures, we can actually describe the BCCs here to be rolled up on its edges together with flattened out center, which is suggestive of a rodent ulcer, sort of like being gnawed out by a rat over a long period of time. Basal cell carcinomas are also traditionally thought to have no metastatic potential. However, with recent developments, there's actually been studies to show that there is actually a 0.5 to 1% risk of metastases for basal cell carcinomas. And these BCCs, they predominantly prefer places like lymph nodes, lung, bones, and skin. Most of the time, however, it is actually a direct extension of the lesion of the ulcer. And due to its metastatic nature, currently AJCC has come up with a TNM staging for BCCs in its current 8th edition, which you can see here. And the staging, the important parts of it would be that any kind of nodal involvement would denote stage 3 disease and above. Any kind of T4 involvement would denote stage 4 disease, as well as any kind of distant metastases. Squamous cell carcinomas, on the other hand, arises from the squamous cells in the epithelium, and these can result from viral infections, from chronic injuries or ulcerations like a margarine ulcer, burns, or even exposures to radiation. AJCC has also come up with updated 8th edition TNM staging, as seen here, with the major changes being additions of the T4A and B suffix, and also involvements of E and E's in the nodes, and the staging as seen here, where nodal involvement automatically denotes stage 3 disease and above. So managements of BCC and SCC of the skin, not as clear-cut as melanomas, as the choices of treatments determined by many different factors, including the size and also the site of the lesion, together with any kind of anticipated functional and cosmetic results. Other than that, treatment time and cost also should be taken into consideration, as well as the patient's general condition, age, comorbids. Typically, we would still prefer if there is surgery as well as adjuvant radiotherapy, unless, of course, poor anticipated functional or cosmetic results. And if we are ever going to proceed with surgery, it's either through conventional excision or through Mohs micrographic surgeries, or MMS for short. Of course, MMS is considered standard of care, with cure rates of more than 97 to 99% reported for primary BCCs and SCCs. What does it denote? There's a small simple pictograph here which explains about MMS. However, I'm pretty sure everyone is more interested in things like radiotherapy here. So how do we select patients for radiotherapy in BCCs and SCCs? So typically we would prefer older patients, as there is higher risk for new lesions with progress of time in younger patients treated with radiotherapy. Larger lesions within the mask area of the face, particularly things like morphoid or infiltrative BCCs, which we already mentioned has a higher PNI risk. Larger, more than 2 cm lesions involving the lower eyelids, the lower lips, as well as if the surgery would be complicated with atropions and also microstomia. Or, of course, if your patient has refused for surgery, then, of course, radiotherapy is the next best thing. Lesions involving cartilages and also bones would also be considered in for radiotherapy. However, it needs to be explained to the patient that there is going to be increased risk of radionecrosis. And whenever lesions involve places like the lower leg, the back and dorsum of the hand or the foot, We will then need to reconsider about radiotherapy as well, because these are known to be watershed regions and poor healing may occur after radiotherapy. So for the planning, most of the time we'll need to immobilize patients. If it is within the head and neck region, of course with BDS, and if we are going to be using a BDS, it would be above. If we are going to be using a lead shield, it would be above our BDS. Bolus placements, we will need to use wax boluses if there is inhomogeneous surfaces, mainly to homogenize off the standoff and also stand-in effects from our electron treatments. Wax-covered lead shields are also used to reduce backscatter electrons when low MeV beams are used, and these are typically placed downstream from where the tumors are. So these are examples of an eye shield, and this is a wax-covered shield that we are using for the mouth to prevent backscatters. And this is a lead cutout for a patient who's having a skin carcinoma on the left side of the nose, much akin to this patient where we used a lead cutout, lead shield for her treatment. And just like what we mentioned, the stand-in and stand-out effects. So after we have chosen the patient for the radiotherapy treatments, how do we choose what kind of radiotherapy treatments? Uh, of course, whenever we're talking about skin, we are talking about either superficial x-rays or electron treatments. So superficial x-rays are more useful in tumors that are less than 4 cm in diameter or less than 5 mm in thickness. The increased absorption towards bone and also cartilage because of the photoelectric effects from superficial x-rays actually increases the risk of necrosis if the tumor actually overlies on a cartilage. There is also some lesser dose fall off at depth for superficial x-rays. Hence, more dose is actually delivered to the deeper lying tissues, and that has to be taken into consideration. Electrons, on the other hand, is useful for tumors that's more than 1 cm thick and also larger than 4 cm. The isodoses constrict at the depth, especially with smaller fields. Hence, we are going to need to avoid electron treatments in fields lesser than 3 to 4 cm in diameter, as that is going to compromise our dose homogeneity and also our dose delivery. Of course, when we are talking about any kind of oblique angles or any kind of inhomogeneity to the body surfaces, the dosimetry is going to be less reliable. So between BCCs and SCCs, most of the time, if we are talking about a PTV for BCC, it is from the gross tumor itself with a margin of about 0.5 cm up to 1 cm if it is morphoid, or large, being more than 2 cm in tumor size, infiltrative or poorly defined, together with at least a 0.5 cm depth margin. And for SCCs, the PTV would be the gross tumor with a 1 cm margin laterally up to about 2 cm if it is large, infiltrative, or poorly defined, and also a 1 cm deep margin. So Khan has also defined in his paper in Radiotherapy Oncology, for BCCs that are less than 2 cm, we consider them low risk, and hence CTVs or the PTVs would be a GTV with a 1 cm margin for superficial x-rays and also a 2 cm margin for electrons, ensuring that your field size is more than 4 cm. And for large or high-risk tumors, it would be a GTV plus a margin of 1.5 cm for superficial x-rays and 2.5 cm for electrons. So taking this lady for example, you will then mark the edges of the tumor with the dotted line as seen here and a margin of 0.5 cm. And for SCCs, he has described that for small, less than 2 cm, or low risk tumors, the GTV would be with an expansion of 1.5 cm for superficial X rays and a GTV with an expansion of 2.5 cm for electrons. And for large or high risk tumors, it would be a GTV with a 2 cm expansion for superficial X rays and a GTV with 3 cm expansion for electrons. So for this SCC, as seen here on his scalp, even though each individual lesion there seems to be quite isolated, however, the indurated region is all connected. Hence, we are doing a 2 cm margin from the indurated regions. And if you were to see here, this is actually a 9 MeV electron beam dose distribution. If you were to see, there is the peripheral bowing of our beam dose distribution. So what kind of hypofractionated radiation therapies for BCCs and SCCs that we can use? Uh, there has actually been a paper by Zayowski that says that there is good cosmetic outcomes in up to 80% of the regimens which achieve a BED of about 100 grays. So for low risk BCCs and SCCs, most of the time we are talking about a hypofractionated dose equivalents of about 60 to 64 grays in 2 gray per fraction treatments. So these would include things like 32 grays in 5 fractions, 50 grays in 15 fractions, 55 grays in 20 fractions, and even 40 grays in 9 fractions. And in high-risk BCCs and SCCs, we are talking about achieving an equivalence of about 66 to 70 grays in 2 grays per fraction treatments, with examples of it being 35 grays in 5 fractions, 45 grays in 10 fractions, 62.5 in 25 fractions, and even 32 grays in 4 fractions. Moving on to non-melanomas. Merkel cell carcinomas are the primary neuroendocrine carcinomas of the skin, and these are usually rather aggressive neuroendocrine cancers with IHCs of CK20 positive and CD56 positive, while being CK7 and TTF1 and S100 negative. The primary managements for these Merkel cell carcinomas are still through surgery with wide local resections. Of course, radiotherapy is to the primary if it is not resectable or if surgery is not possible, causing either functional decline or cosmetic problems. If we are going to go on with definitive treatments with radiotherapy, we are aiming for doses up to about 60 to 66 grays in 30 to 33 fractions, or with 55 grays in 20 fractions, and we can consider giving it as per a CCRT with etoposide and cisplatin, considering that it is, after all, a neuroendocrine carcinoma of the skin. And this is the AGCC TNM staging for Merkel cell carcinomas, also of the 8th edition. So for Merkel cell carcinomas, if in the event of an adjuvant radiotherapy, we are aiming for 50 to 60 grays in 25 to 30 fractions, and this has been shown to reduce the risk of local and regional recurrence by up to about 73 to 66% respectively. If it is a T1 lesion and is low risk in the sense that there is no lymphovascular invasions, no sentinel lymph nodes, then you can exclusively treat just the tumor bed. However, if there is more than T2 disease, or if there is signs of lymphovascular invasion, or even if nodes are positive, then you are going to need to treat the excision site as well as any in-transit sites as well, and that includes lymph nodes as well. So far we've covered the melanomas and also 3 of the most common non-melanoma skin cancers, which is our basal cell, which typically looks like a rodenoid ulcer, a squamous cell carcinoma, which looks like a fungating kind of a lesion, and a Merkel cell carcinoma, which typically looks like a very red, angry looking bump. So much like the four horsemen of the apocalypse, right? Other kind of non-melanoma tumors will be looking at things like cutaneous T cell and also B cell lymphomas, as we can see in this series of four pictures here, with A being the cutaneous lymphoma in the patch stage, B being in the plaque stage, C being in the tumor stage, and D being in the erythrodermic stage. So T cell and also B cell cutaneous lymphomas are relatively quite common. However, the commonest is still a cutaneous T cell lymphoma, with its frequency up to about 39%. And due to that, there's already been a lot of stagings that has been created for these cutaneous lymphomas, but the most commonly used is still the ones by ISCL, which is the International Society of Cutaneous Lymphomas, and also the EORTC modified staging, as you can see here. And based on the TNM staging from the ISCL and also EORTC modified stagings, we can then reclassify them as per early stage in the 1A to 2A disease and advanced stage in the 2B to stage 4 disease. Of course, whether they are in the early stage, advanced stage, or in the late stage, treatment for mycosis fungoides or cutaneous T-cell lymphomas is still, after all, with total skin electron beam therapies. So, management of cutaneous T-cell lymphomas in the local control, there's always options for topical corticosteroids or topical chemotherapies, photon therapies, and even local radiations to specific regions with localized disease. However, if there is extensive disease options, then we are talking about total skin electron therapies, which typically achieves a dose of about 30 to 36 grays over a period of about 6 to 9 weeks. And this is actually a very highly effective treatment option with complete response rates of up to about 95% for T1s and up to about 74% for T4 diseases. So when we are talking about total skin electron beam therapies, most of the time, I believe a majority of the centers are using a Stanford technique, and this uses 6 separate dual field treatments, with each dual field consists of one field angled upwards about 20 degrees and the second one angled downwards about 20 degrees, matching in the middle at the 50% isodose line to ensure that the dose delivered is still accurate. The source to surface distance is usually kept about 3 to 7 meters, and that should be sufficient to cover the entire length of the patient body. So if you were to see a picture, it's sort of reflected like this, where the two fields would be one at a 20-degree angle upwards, the other one angled downwards at 20 degrees, and overlapping in the middle at the 50% isodose line. We are also doing a 6-field sort of coverage. Hence, patients will be separated into a day 1 field, a day 2 field, where they have different positions for treatments. Important points to note is that usually the patients will be elevated off the floor, and that is to actually reduce the floor scatter dose. And a scatterer is typically placed about 20 cm in front of the patient, which would induce large angle scattering and improve on our dose uniformity, but that would instead reduce penetration and leads to a less steep dose fall off. Boosts for these patients are also typically necessary, as there would be regions where the patient would be underdosed, and we expect those regions to be the inframammary regions, the perianal regions, the inner buttocks as well as the inner thighs as well as the perineal region. And sometimes if the patient has a lot of tumor stage disease, these thick cutaneous tumors may also require a boost, each to their individual depths. So these patients also, whenever they are doing their total skin electron beam therapies, will require adequate shieldings, and these would include places like the eyes, the fingers, especially at the nail areas, and also the tops of the feet, also mainly because of our nail beds. Common shield thickness for 4 MeV electrons is typically up to about 2 millimeters, and eye shields are likely to be a bit thinner as they are placed underneath the eyelids. Most of the time, if we are talking about complications, it is these three things up here about erythema, temporary alopecia, and also nail stasis happening up to about 100% in incidence. Other than that, mortality is actually very, very low, almost virtually none. Most of the time, if we are going to be prescribing it, we would be writing it as total skin electron therapy treated to 36 weeks over 36 grays over 9 weeks, up to 4 grays a week, for 4 days in a week, 3 dual fields per day. Most of the time treated on day 1, day 2, with day 3 a rest day, and day 4 repeating the fields in day 1, and day 5 repeating the fields on day 2. The eyes will be shielded throughout, with the scalp shielded after 25 grays if there is no involvement above the neck, and protecting the feet with 20 cm high lead shields after the first 10 grays when you start the sole boost. Any other alternatives to the treatment of um, total skin electron? Yes, you can actually plan it using a helical arc radiotherapy of total skin, or HARTS in short. Typically, what this is just doing your total skin electron treatments with thermotherapy. And this can actually overcome the challenges posed by circumferential and also multifolding nature of the human body skin surface, and it will also reduce the inhomogeneities that we see. The CTV is actually defined as the contoured body with a 5 millimeter inner margin, with a PTV expansion of up to 5 millimeter on an inner margin, and also a 3 millimeter on the outer margin. So for the dosimetry, you will also need to put in a central core complete block, which is a region where you block off the doses so that you can preserve all our OARs on the central regions, and also specific OARs like lungs, eyes, lens, kidney, and marrow will then need to be contoured separately. So patients that are going for heart therapy would usually need to be in a wetsuit as a bolus, and the plan would look something similar to this. Other non-melanomas would be the relatively rarer ones, things like adnexal adenocarcinomas and porocarcinomas, which arises from your sweat glands, angiosarcomas of the scalp, Kaposi sarcomas, and also extramammary Paget's disease. But these are all things that we will not be covering during our lecture today. Any questions from the floor?